Uh,
Everybody wants to hear what you think, if it's going to turn positive or negative.
I think it could be a positive trial. I'm convinced it could be a positive trial. So what's gonna optimize the difference between the HIPEC treated group using the Dutch high dose mitomycin C and no HIPEC at all? Well, um, if the patients have the proper cytoreductive surgery, if your quality control of that surgery is, let's use the word perfect. I know that it's a hard concept, but we need perfect surgery, not a quick 3 to 4 hour small abdominal incision and everything is okay. No, every single site for occult metastases needs to be dissected out. It needs to be perfect cytoreductive surgery, and then it needs to be patients who are are good candidates for randomization. In other words, their PCI is not in the stratosphere, it's not above 20, but
Mhm.
there also is tumor there. And those patients who have no tumor or have had a almost complete response, they're not going to profit from HIPEC because they're not going to have any free intraperitoneal cancer cells. So those patients who have had, the two groups of patients with colon cancer who do extremely well with CRS and HIPEC are, number one, those who have negative lymph nodes, and they're
Yeah.
looking at 60% at 10 years. And the other group are those who have a complete or near complete response to systemic chemotherapy, and they're going to have a median survival of 6 to 7 years. Actually, you're the first one to show that in the
High grade appendiceal.
high grade appendiceal. What was it? Gastrointestinal Research and Practice. So that group of patients is not going to profit from HIPEC. It's that middle group. We saw them in Prodigy 7. We saw that middle group of patients who had a moderate PCI, so they're very likely to have positive tumor cells. It becomes a matter of trying to match up a patient who will profit from intraperitoneal mitomycin C with the patients that are entered into the protocol. And it's not an easy problem, and there's liable to be a lot of noise in the system, which may obscure the positive effects of the high dose or moderate dose mitomycin C. But I think
Yeah.
it'll be a positive trial, but it depends on getting those two groups of patients out of there. You have to have perfect surgery, and you don't want patients who have no tumor or almost no tumor left behind, because they're going to have a 7 to 10 year median survival anyway.
Yeah, I think that's interesting prediction, and very interesting comments, and actually, if I have the same feeling, and we try to sort of explore a little bit this idea that a different HIPEC might be a different response or different effect in colorectal, and we did a retrospective analysis because, of course, after Prodigy 7. Our institution changed the HIPEC from the short oxaliplatin that was used before to mitomycin C, and we try to, at least short term, look at the peritoneal control, and it seems to be better in patients who have had mitomycin C. Actually, what we use is a combination of mitomycin C and cisplatin. But we'll see. We'll just see. I'm glad that the study's going on. I think it's a good thing, and it will be some really interesting discussions when the results come out. There is another aspect of PRODIGE 7 that you criticized, and it's probably one of the aspects that got most attention, and rightly so, and that is the impact of neoadjuvant systemic chemotherapy on basically the whole thing, on how we think about HIPEC, whether it can be useful or no, how do we set it up, how do we choose it based on the neoadjuvant that was received. And in this question for colorectal cancer, of course, one of the main criticism was that we used the same drug. We used oxaliplatin for neoadjuvant, and then we kind of used it up, and then we wanted to use it again and wanted to see the effect during HIPEC. So that was very logically a question that was debated a lot. But then I think of other recent HIPEC situations where the HIPEC was not a disappointment like it was in PRODIGE 7, but it was actually a big win. Actually, I would say a surprisingly big win, which is the OVIPEC trial in ovarian cancer. Mm-hmm. And when you look at that, you see that it's sort of exactly the opposite. These are all patients that are pre-treated with neoadjuvant systemic chemotherapy with cisplatin. And this was not only the OVIPEC trial, it was also other ovarian cancer trials where exactly the pre-treated, the neoadjuvant group was the one that benefited from HIPEC, which of course contained cisplatin again. So what are your thoughts about that? Why is it so different for ovarian cancer? And of course, it's a different disease, but conceptually, selecting out resistant cells should be similar. Why is it so different? And could be that the big difference here is the main player, which is the drug.
Mm-hmm. Yes, I think you're right that the major difference is the drug and the response of ovarian cancer to that drug. You just cannot compare the effects of cisplatin on ovarian cancer with the effects of oxaliplatin alone on colon cancer. I mean, there's no difference. It's a 60-70% response rate versus a 13% response rate. So there's a huge difference in the drug. Now, of course, and we've talked about this before, there's a big difference in the hyperthermia. And I don't think hyperthermia is the most important part of HIPEC, but we basically had no hyperthermia. I mean, it was 43 degrees, but for such a short time, you would not expect it to, by any experimental studies, to have any effect, versus a full hour of hyperthermia. And we see this somewhat strange, and maybe I don't completely understand it, this strange situation where if patients have a response, not a mediocre or small response, but if patients have a complete or near complete response to systemic chemotherapy, and then we do cytoreductive surgery, either with or without HIPEC, I'm not sure it makes any difference, that group of patients does extremely well. And I think there are a lot of patients like that in the Van Driel, in the Dutch ovarian cancer trial. They had a marked reduction in the amount of ovarian cancer that they had. They went in, all the sites of obvious persistent disease were removed by the cytoreduction, and that's a group of patients who do extremely well with colon cancer, even with gastric cancer, by the way, but I think especially with ovarian malignancy. So I don't think it's difficult to explain both pharmacologically and from a natural history perspective, why OVIPEC trial worked and Prodigy 7 was such a failure.
Yeah, I think that's a very good sort of last comment, because I think we tend to sometimes a little bit oversimplify our ideas around HIPEC, and perhaps people who are sort of less into the topic even more so, and sort of try to have one explanation that fits every disease and every drug for HIPEC, etc. And this sort of level of nuance in interpreting trial results and thinking about how to set up the next trial, I think it's necessary if we want to continue studying HIPEC. So towards the end of your article, you talk a little bit about things that are really sort of variations on HIPEC, but important variations that maybe need to be considered for the future. And one of these concepts is really not limiting HIPEC to one treatment or IP chemotherapy, maybe more broadly, both in the pre-operative cytoreduction setup. And we have some really interesting trials using repeated HIPEC, for example, laparoscopically for gastric cancer, that turned out with some interesting results. And then I would say even more new and a bit radical is to repeat HIPEC post-op, give it more than one treatment. So tell us a little bit about your thoughts about this. Is one-time HIPEC just insufficient and we really need to move towards multiple treatments? And where is the better setting, pre-op or post-op?
Well, the number one criticism of HIPEC by the medical oncologist is that it is a single treatment and cannot be repeated. I mean, it's done by the surgeon in the operating room. What chemotherapy regimen that the medical oncologist uses is a single treatment?
Yeah.
Now, I don't know, gene ablation, that could be, I don't know. The concept of getting a reasonable response from 90 minutes of treatment one time is, from a medical oncologist perspective, unreasonable. And there's still a large number of medical oncologists who think what we're doing is totally, from a pharmacologic perspective, is totally and completely unreasonable. Well, why not use the HIPEC? Or I'm not so sure that it's necessary that it would be HIPEC, but if you can arrange that on the nursing unit as they do in China, apparently it's I've seen it used. It doesn't seem to be a big deal for them. I think that a double HIPEC, a triple HIPEC, a quadruple HIPEC is completely reasonable and is much more likely to have the effects on small volume residual disease, on microscopic residual disease that we would like to see. Now, I would wonder if I'm not a great fan of PPAC, and that's probably because I've never used it, but I'm really wondering if for all those times that PPAC is used, you would just use a HIPEC. Would the HIPEC used in a serial fashion, like PPAC has been used, would it be just as effective? Might even be more effective. I don't know. But I think that the repeated doses of cancer chemotherapy after complete cytoreduction and HIPEC, I think HIPEC is necessary the article that I wrote doesn't in any way say HIPEC should be thrown out. This is not throwing the baby out with the bathwater. Yes, we do need HIPEC. It has a very important function, but we should be using repeated doses of combined intraperitoneal and systemic chemotherapy. And it's a little bit of a technological issue. I'm a little surprised at how big a technological issue it is, because I've used intraperitoneal chemotherapy for 3 decades and never had any huge problems with it. I mean, we had to laparoscopically retrieve catheters, and we had to, pull off some and replace catheters sometimes. I'm hopeful that a new catheter, a new intraperitoneal access device is going to be available to us in the near future. Actually, it's a Spanish product. But I would think that repeated HIPEC at the time of surgery, and of course that is the best time, isn't it? That is the best time, in that 5 to 7 days where we have a minimal or no adhesive process within the abdomen and pelvis. That's the best time to get the drugs in. And I would be a strong proponent. I wish I could generate the protocol at this point in time, compare 1 HIPEC to 3 HIPECs, and see what happens on down the line. By the way, it would take a very nursing staff to do that, and they have that in China. I'm amazed at how the nurses just wheel those patients into this little side room and hook them up to the rather crude HIPEC machine, and it just all seems to happen all. And I saw one fellow, he was standing up and kind of moving things around as he was getting his I think it was his 3rd HIPEC. So things that you think, oh, well, they can't happen. Yes, they can happen. We gave early postoperative intraperitoneal chemotherapy for decades, worked out just fine. We could easily have, and I wish we could easily have translated that into a triple HIPEC.
Yeah, well, I think it's really interesting for you to tell us about these variations on HIPEC that honestly I didn't think conceptually possible, to give HIPEC, heated intraperitoneal chemotherapy, to an awake patient on the ward. But then again, there are people who are absolutely convinced that EPIC cannot be done, and I can attest to the fact that it's most certainly can, and without so many difficulties. So I think it's important for us to consider how much we are limiting perhaps the power of HIPEC by giving it only as a single treatment, and perhaps we expect a little bit too much from this single treatment. So I think
could I interject something here, Lana, just very quickly? I think this concept of HIPEC is necessary but not sufficient, from my perspective, has been shown extremely clearly for peritoneal mesothelioma. In our studies with peritoneal mesothelioma, we're bringing, and I still have all of my data on these mesothelioma patients who had not only a very careful, meticulous cytoreductive surgery, and then HIPEC plus EPIC, and then a catheter was put in at the time of the surgery. I'm sorry, an intraperitoneal port was put in, and then they were treated with 6 more cycles of systemic cisplatin and intraperitoneal pemetrexed. That's a 70+% 10-year survival on that group of mesothelioma patients. And the trial was not extremely difficult. Only 1 or 2 patients did not get at least 5 cycles of the combined intraperitoneal and systemic drug. It can be done. It's just that there is a huge resistance of the medical oncologist to long-term intraperitoneal or combined intraperitoneal and systemic chemotherapy. It's a technological issue, and I'm hopeful by the end of 2024, this technological issue will be overcome.
Mm-hmm. Mm-hmm. Well, I think for me, this has been really very, very interesting, fascinating to hear your thoughts on these things. I think we're getting slowly close to the end of our time, but I wanted to ask you again to look into the future for us, because I think you've seen the future in PSM way, way, way before anybody else could see it. So if we are thinking about, let's say, the main diseases that we treat with cytoreduction, colon cancer, pseudomyxoma, ovarian cancer, mesothelioma, and gastric cancer, what do you think is the future of HIPEC for each one of those in terms of its importance? And you can say it whichever way you prefer. Is the percent of patients who will continue to have HIPEC of all of those who are candidates for surgery, or just important or medium or no? Tell us a little bit how you see that.
First of all, I'm going to say that all of us here, we're familiar with the problems of peritoneal surface malignancy and its treatment. But these concepts of beneficially managing this group of patients is just hitting most of the world. Indonesia is now becoming very interested, several different meetings. Malaysia, I mean, these are people with hundreds of millions of people that need treatment for PSM. So I think that our efforts as PSOGI and ESPSO to develop at this point in time the most reasonable selection factors for cytoreductive surgery and the most reasonable and well-tolerated HIPEC, and present these to our colleagues in South and Central America and in Asia. The problem in China is almost overwhelming, but moving pretty rapidly. So anyway, I would just like to remind all of us that we're kind of living in a bubble here with a lot of experience with treatment of this whole new subdivision of surgical oncology. Now, where should we start our research programs? First of all, I would say the most important part of the whole thing is that we are persistent. The quality of the protocol and the questions are definitely important, but what's really important is that we are trying to achieve answers, and we are trying to identify new and more beneficial treatments. And if aerosol delivery of cancer chemotherapy is going to be part of that, I'm all for it. For me, it's the high risk. We still lose about 40% of our patients with colon cancer. We do much better with rectal cancer than we do with colon cancer. And for me, the development of protocols to identify these high-risk patients and then to define a strategy for the different groups of patients, the different groups of high-risk patients, which are going to sort out, for me, is the number one number one problem that we need to encounter. I think the second one is ovarian cancer. I think we're going to have a major, major impact when we really learn how to use a regional intraperitoneal or combined intraperitoneal chemotherapy and intraperitoneal systemic chemotherapy for ovarian cancer. We're gonna do well. I just can't imagine, to tell you the truth, that we're dealing with a disease. This is now ovarian cancer. We're dealing with a disease that has as its major terminal manifestation peritoneal failure, and our neoadjuvant chemotherapy is all systemic. I mean, we could very easily be using the Taxol intraperitoneally, and if you look at the pharmacology of intraperitoneal Taxol as a neoadjuvant treatment for ovarian, it's wonderful. It really suggests that that's the way Taxol should be given, and so that would be one of the things that I would think about. And the other, of course, taxanes are our miracle drug. So far, they're other than the nanoparticles, which haven't really been well defined, but Taxol and Taxotere are our miracle drugs. FLOT. I mean, Beata Rao showed us that if you initiate FLOT in patients with peritoneal metastases, they're just about as likely to recur. I mean, just about as likely to progress or not. And I think that was the most important reason why patients didn't make it into her protocol. This FLOT was not effective for the. So why not put those taxanes in intraperitoneally? Well, I tell you the reason is that it's not convenient. It's not convenient, and we haven't convinced the medical oncologist that a local regional approach is worth the time and effort. And maybe these intraperitoneal ports do need to die, and we're going to have a better way of administering intraperitoneal drugs. So I guess that's where most of it's up front, isn't it? I'm trying to move HIPEC and intraperitoneal chemo, and I mean, if the systemic chemotherapy is 100% effective, we don't need regional chemotherapy. Okay, and those patients who have a complete response, there's no reason to use no reason to use regional chemotherapy. Regional chemotherapy is the cleanup after a partial or no response to systemic chemotherapy. So we're searching out those groups of patients where we can have a profound effect, I think, early on in the course of the disease, and thereby see our greatest benefit from cytoreductive surgery. And we have a huge burden. I think we have a huge burden to try and teach peritoneectomy to the world, because it's just not out there. So with proper combinations of cytoreductive surgery and perioperative chemotherapy and neoadjuvant and adjuvant, it's pretty complicated, but I think we need to stick with it, and that we're going to achieve great benefits over time.
Well, that's, I think, a great and optimistic and stimulating last thought from you, because it's really been a fascinating conversation. And if I can do a little sort of take-home message from your last comments, is exactly what you said. HIPEC has many controversies, many issues, but still, I think it's on us to continue to study it, and it's probably way more complex to study than than we have realized so far. And I think you, just in these last comments, you gave us probably 10 years worth of work in terms of directions and potential and ideas. And so it's on all of us to continue